يا دكتور.
اكدي معايا دينا كده لو طلع.
ماشي.
هو خلاص المفروض ان هو ببلشنج دلوقتي.
طلع يا دكتور على بروفايل حضرتك.
طيب تمام. Hello. I hope everyone is doing fine. النهارده we have a junior club session, an interesting paper, an interesting review in the journal Periodontology 2000, and the paper was published in 2019. It discusses the effect of the restorations, the suprastructures or the implant restorations on the development and progression of peri-implantitis. We have a very interesting topic, a very interesting paper that's going to be presented by Roa Mustafa, one of the prominent team members of the Peri-Implant, our Peri-Implant Education Club. I'm really proud of you. So let's start.
Okay. Thank you so much, Dr. Nada. Thank you for giving me this opportunity today. Today, inshallah, we're going to discuss a review article. And review article, it has some above multiple previous studies and conclusion of this studies. We are going to discuss restorative design and associated risks for pre-implant disease. And to understand the topic we are going to discuss today, we have to understand each terminology in the title. So first of all, we are going to talk about what is the pre-implant disease. Pre-implant diseases is both the pre-implant mucositis and pre-implantitis. Pre-implant mucositis is simply as the gingivitis, but in implants, inflammation of gums around implants.
Mm-hmm.
So it could be reversible if we remove the cause. And about pre-implantitis, it is the same as pre-mucositis. In addition to, there is destruction in the surrounding bone.
Mm-hmm.
So this is the pre-implant mucositis, inflammation of gums around implant, and this is pre-implantitis, inflammation of gums in addition to destruction in the surrounding bone.
Mm-hmm.
Here, the pre-implant mucositis, and here, the pre-implantitis.
Yes, it's much like for those who are not oriented with the term, it's much like the difference between gingivitis and periodontitis around teeth. So which of them do you think is reversible, or is it really reversible or not? What do you think?
Of course, the gingivitis is reversible, and the same mucositis,
Mm-hmm.
and pre-implantitis as periodontitis.
Mm-hmm.
We can stop it. We can stop the progression,
Mm-hmm.
but it's not reversible. You cannot go back to the original state.
Mm-hmm. So as much as we discussed last time with Dina in Dina's session, that we said the peri-implant mucositis may not be 100% reversible, but we agreed that it might be reversible, but with a longer duration of healing than the regular gingivitis around teeth. But still, we consider that peri-implant mucositis is a treatable, reversible disease, while peri-implantitis is an irreversible one.
Yes.
Very good. Okay, let's go.
So the pathogenesis of the pre-implant disease is similar to the periodontal disease, and it could affect 50% of American adults, according to the National Health Surveys.
Mm-hmm.
Okay, concerning the prevalence, Dina talked about the prevalence, and she talked about that multiple studies has published multiple prevalence. This is due to that each study focus on different factors. So there's a wide range of prevalence in each study. But according to my paper today, and according to the recent analysis, the pre-implant mucositis occur in 65%, and pre-implantitis could be 47%.
Mm-hmm. Mm-hmm. So we have like a general agreement that peri-implant diseases represent around 50% of the implants we have.
Yes.
It's like it's like a general percentage, a general term. It's like half of the cases. You just think of it like half of the cases.
Yes.
Yeah. Okay.
So, okay, we are going back to the title. We discussed the pre-implant diseases, and now we are going to talk about the restorative design and how it affects the pre-implant diseases.
Mm-hmm.
Okay, talking about the restoration of the implant. What do I want from the restoration above the implant? Yani what should the restoration above the implant give me to prevent or to pre-implant disease could not happen? First of all, I
to maintain the peri-implant health.
Yes. First of all, I want the restoration to allow me as a dentist to do proper diagnosis. I want to put the probe around the implant and could get proper probing depth. I could see if there is a bleeding on probing or not. I could see if there is any suppuration or any bleeding around implant. So the restoration shouldn't hinder me from doing this.
Very good.
And second, the oral hygiene, both for me as a dentist and for the patient. For me, in the maintenance visits, the restoration shouldn't be there shouldn't be any problem in doing the curettage in the visits, and for the patient in the home, he should do proper oral hygiene with restoration. So, talking about the oral,
and this could be a message to all our friends who are not periodontists, so that they have the periodontal probe and they use the periodontal probe. And they check the peri-implant mucosa and they check the periodontal tissues. This is really important. With your routine checks, you have to check with the periodontal probe if everything is going fine, if there is bleeding, if there is increase in the pocket depth, and so on.
Yes. So talking about the oral hygiene, we're going to review, I'll give you some of the studies that had done before about this issue. Okay, oral hygiene. First of all, in a direct comparison between of implants that have proper access for hygiene and implants that does not have proper access of hygiene, pre-implantitis occur in 48% of implants that does not have access for hygiene, and only 4% in implants that have proper access for hygiene. This is remarkable. Second of all, 2011, Ricky et al. Reported that there is a lower risk of pre-implantitis in patients with good access for good oral hygiene. And I don't know, this is scientist pronunciation of this.
Jetterson.
This is
Jetterson.
Okay. Jetterson et al. Reported that the patient with periodontitis or pocket depth more than 5 millimeters has a significant risk for pre-implantitis. This is how important the oral hygiene maintaining the pre-implant health and the pre-implant tissues.
And once again, the myth is dying. The myth of that there is no true peri-implantitis and that there is no true peri-implant diseases caused by bacteria and plaque and deposits. The myth is again dying. We were told, like 10 years ago, we were told that there was no true peri-implantitis and that peri-implantitis usually occurs due to functional overload. I know that you are going to discuss the functional overload because they discussed it in a paragraph at the end of this paper. So now we are thinking differently about the etiology and the progression of peri-implant diseases. It's much like periodontal diseases, very regular and very logic to think of.
And still the hygiene is major factor than the occlusal overload.
Yes, exactly. And it gives us a huge alarm about patient selection.
Yes. Going back to the prosthetic design. Okay, here is the prosthetic design. First of all, I want the prosthetic design to have a good emergence profile, meaning that the supragingival restorative zone and the subgingival restorative zone shouldn't be over contoured, should allow the proper the periodontal probe to not have any deflection or deviation during the measurement of the probing depth, during seeing if there is a bleeding on probing or not. Second of all, the restoration should have a good contact point, and contact point is affected by multiple factors. First of all, the position of the implant. If the implant is going too mesial or too distal, contact point of course will be affected. And concerning the restoration, the contact point should be more occlusal than middle and the gingival, because it allows for more oral hygiene and allow me as a dentist for proper diagnosis, putting the probe and whatsoever.
So here, what you are saying is that you actually have to avoid having the contact area too apically.
Yes, as much as I can, I should go occlusal.
To give the space for the periodontium to grow and fill this space, and fill this area.
Yes, yes. And for allowing for hygiene also.
Good.
Second, we are going to talk about the implant platform. What is the implant platform switch and what is the non-platform switch? The platform switched implants is simply that the abutment and both the abutment and the implant have the same diameter. Okay. Having this, that they have the both diameters, both similar diameters, we can see on microscope. Sorry. On load.
I really love this one.
On loading, there's this gap happens when occlusal load occur. If we have both the implant and the abutment having both diameters. This is called non-platform switched implants, okay? This gap, they say that it is measured 10 microns, and the diameter of the bacteria is only 2 microns. So this gap can allow for both invasion and colonization of bacteria, and which could affect the periodontium and cause pre-implant diseases. So they came up with another perspective that we can make an implant platform switch, which there's the difference between the diameter of the abutment and the diameter of the implant. This gap allows for more bone gain and also for biological width to be in the implant. Okay. Dina,
do you need to ask a question?
Yes, yeah, doctor. In the previous slide, the contact point, يعني, does the insertion depth of the implant have something to do with the contact point? يعني, how to apply it clinically?
I think you're going to discuss the depth thing, Yaru'a. You're going to discuss it later.
Yes.
But here,
how to apply it clinically? We should, first of all, insert the implant in proper position concerning mesial and distal. It shouldn't be more mesial, it shouldn't be more distal. It should be proper. If it is more mesial, the distal contact point will be
over contouring.
Yes, there will be over contouring. This is first of all. Second of all, when you do the restoration, you should allow the restoration, the contact point to be on the occlusal as much as you can. Occlusally, not typically.
Yes.
You can do this with the prosthetic design, either the wax up if it's manually done, or with the CAD CAM or whatever technique you're using to design the crowns. Do you get it, Yedina?
Oh yes, doctor.
Yes. And about the insertion depth, we're going to discuss this in details.
Yes. Okay. Going back to the platform. So in the platform switched implants, we have more bone. We have more area for more bone to grow here and for the biological width. So lately, every study and every paper have been talking about that how the platform switched implants are very nice and very good and whatsoever. So here, the platform switched implants increase the distance allowed for biological width and less bone remodeling. This could be applied theoretically. Theoretically, okay? Today, this is only theoretical. We have to see clinic. So we have to study the actual expected results of this phenomenon. Okay, let's see. First of all, the effect of platform switch phenomena has been studied in RCTs and cohort studies. Okay, there's a study that said that clinically, that statistically on papers, the amount of bone gain we have from the platform switched implants is high on papers, but clinically it is small. When you have gain of 0.25 millimeter or 0.3 millimeter of bone, this is on papers is a great number, but clinically it's not that big. The first study said so. The second study said that there is some studies showed no difference between the bone gain in a platform switched implants and non-platform switched implants. There is another systematic review that said that we can gain up to 0.5 millimeter in platform switched implants, but there was heterogeneity of the data and publication bias, which could resist me from taking this as a strong conclusion.
Yes.
Another study said that there is no difference in implant survival rates between two types. Yani I could gain bone in platform switched implants, but on surviving, both implants will survive. Okay, so in RCTs with a 3-year follow-up, there was no significant difference in bone height. Other RCTs with a 5-year follow-up, there is only a bone gain 0.3 millimeter in the first year. But from this up to 5 years, there was no change. Available research indicate that the platform switched implants could let me gain 0.4 millimeter of bone, but this does not affect any of the patient outcomes. So this studies is giving me somehow a debate or another point of view concerning the platform switched implants.
Let me ask you something. As a researcher, if you are involved in clinical trials, hopefully in the future, in the very near future, if you are thinking like a researcher and you read this amount of data about the platform switched implants versus the regular implants or the matched implants, what comes into your mind? What do you think that we need? Do you think that we still need more evidence? Do we still need more papers, or do we have a conclusion?
What I conclude, doctor, from reading this, I shouldn't only rely on one study or literature. What they say. I should know what to do when. And see what I have. Here in the study, in this article, they say you can make platform switched implants when you have that the diameter of the implants is same to the diameter of the lost tooth you are going to restore. So you are going to have a good contour of the restoration. So you can have platform switched implant and you can gain that much bone. You can benefit from this bone that you gained.
Yes. This is thinking like a clinician. This is thinking like if I'm a clinician and I need a decision in a choice of my implant, somewhere I'm putting an implant in the upper central or the lower molar, for example. So I need to choose an implant. What should I choose? Should I go for platform switched or not? Are we conclusive or not? But what do you think as a researcher? Because the first thing that came into my mind as a researcher, because we are conducting a study about the difference between the two types of implants, of designs. So what came into my mind first is that this study is really valid. We still need further studies. Yes. We still need more evidence, because even in the systematic review, we had heterogeneity. So if I want to conduct or to get conclusive data, if platform switching is really effective or really does make a change, we still need further studies. So the first thing that came into my mind as a researcher is a validation of the randomized clinical trial we are conducting right now. And I was really happy about this. The second thing is that here, when they discussed the difference between the two designs, they only mentioned bone gain. Like this is the only outcome I should be measuring. What do you think? Do you think we have other stuff to think about?
Yes, we have that the attachment that we gain. So we are
exactly, and the amount of interproximal inter-implant papilla and the amount of soft tissue attachment around. There is a difference in the papilla height and papilla width and the amount of soft tissue gain. This is really a very important clinical and research outcome to think of.
And this is another bias.
Yes, and this is actually
mentioning this.
because maybe you don't get that much of bone, but you gain that much of soft tissue, and then the difference is really going to be huge or significant, clinically significant. Good.
So
Right.
this is another bias on mentioning only these studies.
Yeah, actually, it was a bit alarming for me. I thought to myself, why are you just mentioning bone while we are talking about peri-implantitis, and we still need to think about the pocket depth and the amount of soft tissue around? But maybe this outcome was not measured in the literature enough.
Yeah.
So again, this was another point giving me a validation of the trial we are conducting.
Yes.
Yes. Yeah, go ahead.
Okay. So again, for thinking of the prosthesis we are going to make, platform switched implants allow for me a very narrow start of the prosthesis that I'm going to have. So there will be over contoured restoration in comparison to the non-platform switched implants, where there will be a regular restoration. So I will not have any problem concerning the over contouring. And they said that if I make a platform switched implants and I gain an amount of bone, this amount of bone will be lost if I make an over-contoured restoration above it. So it will have plaque accumulation and bacteria and, of course, pre-implantitis, causing me to lose the bone I gained from making platform switch. So again, when to do what?
Yes.
So here we can make, as I said, the platform twist implants if I have the diameter of the implant and the loose tooth are the same, and I can assure that I have the final restoration and the provisional restoration maintainable for both the patients and for the dentist.
Professional cleaning.
Yes. So talking about the vertical position of the implant. Okay. If I place, they said that if I place implant too shallow, there will be an acute restorative angle, and if I place it more deeper, there will be obtuse restorative angle. Acute restorative angle will allow for less access of hygiene, and obtuse angle will allow for more access for hygiene. Let's see how on a photo. This is the angle we are talking about. This is if I'm placing the implant shallow implant, the angle will be more acute, and if I place it a little bit deeper, this angle will open slightly, so it will be more obtuse, allowing for more access for hygiene. And this takes me to, again, the question when to do what. If I have an implant with a small diameter, 4 millimeter, I will need place it more deeper than the implant with 6 diameter, which I can place it more shallower because of this angle. The implant of 6 millimeter will allow a proper obtuse angle, so allow for good access of hygiene. But the implant of 4 millimeter will need to be placed more deeper, so this angle will be more up.
Very interesting, especially if you are replacing a molar, a lower molar, or an upper molar, where the crown is really huge.
Yes. Again, talking about the crystal or subcrystal position of the implant, it does not affect the total bone loss. They said that according to a recent retrospective study, it does not affect the total bone loss. If I was concerning about the other parameters as delayed loading, minimal disturbance of the implant abutment interface, and platform switch concept. Type. If it's more advisable to put the implant deeper than to put it shallower. But if I have a problem in placing it deeper because of any anatomic variation or any prosthetic variation, so I could place more wider implant to allow me to place it more shallower than the narrow implant, which I have to place it more deep. So I can play with this.
So according to the amount of bone you have buccolingually and mesiodistally, and accordingly the choice of the implant diameter, you can choose whether to place it more deep or more shallow.
Yes.
Very good.
Okay, talking about the prosthetic design. Okay, if I have a fully edentulous patient and partial edentulous patient, of course, the fully edentulous, and we are going to restore both of them with implants. If the fully edentulous patient will have, of course, less access for hygiene than the partial edentulous patient. So, of course, this is يعني should be done before إنه أكيد the fully edentulous patient will have high plaque scores and bleeding index and will have more peri-implantitis than the patients of partially edentulous.
But they actually specified something. They specified that there is a higher risk for peri-implant mucositis, and there is always inflammation around the implants, but not necessarily more bone loss. I read
Yes, I was going to mention this, yes, in the... I was going to mention this, yes.
Yes, take your time.
Yes, I was going to mention it here. I know the authors... yeah. Yes, you know, the survival rate is similar. Yes, that there is more like gingivitis or inflammation of the mucosites, of the mucosa, than actual inflammation lead to the losing of the implants, yeah.
Because you also, you know what, if you noticed or you have seen an amount of patients with the overdenture superstructure, you always find that there is lack of keratinized tissue. So that you have a problem of inaccessibility of hygiene, and those patients cannot really clean well because their implants are really embedded below their dentures. So the accessibility for cleaning is really poor. Plus, that most of the time, those patients come to you with a huge amount of bone loss, vertical and horizontal, and soft tissue loss. And not all the people go for soft tissue augmentation and keratinized tissue augmentation around these implants. So you find that those patients are inaccessible for cleaning and having a problem with the peri-implant mucosa that it's most of the time non-keratinized. So the problem is doubled.
Yes.
And the knowledge of the quality of soft tissue around implants is really important for everyone who's placing implants.
Yes, that's what I was going to say. So
I'm going to shut up. I'm just
لا والله العظيم لا. I'm trying to focus. الشكل غبي بس والله ما افهم والله.
لا, you're doing great. I'm enjoying so much.
يعني كذا ملامح وشي انا ما افهم والله. Okay, going back to the prosthetic design. I have to remove this. Okay. Splinted and non-splinted restoration. Splinted restoration, we are going to talking specifically about overdenture. And we are going to talk about the design of the overdenture. If the overdenture is designed on implants that have splinted, that they are splinted implants, and overdenture that have non-splinted implants. Of course, non-splinted implants is more accessible for hygiene, so there is less mucosites and less implantitis than this design, which here I cannot maintain good oral hygiene, so more plaque accumulation, more inflammation, of course. So the implants with or the restorations with design that have non-splinted implants is more advisable. And talking about the occlusal overload, okay, they said that in this paper that the occlusal overload as an entity is not causing an inflammation, but it can cause screw fatigue or loosening or separation of the abutment, and this all can cause the inflammation. But the occlusal overload as an entity is not very remarkable in causing the pre-implant disease.
And again, the myth is dying.
Yes. Okay, talking about the implant cantilever designs, the non-axial implant cantilever has, of course, a bending force and the non-axial loading, so it can be transmitted to bone and cause more bone loss. So it's more advisable in the designs which I have cantilever. I can increase the number of implants to distribute the forces and cause more bending forces and cause more less bending forces and less resorption of bone. Okay, here talking about the crown to implant ratio. This is يعني أول مرة بصراحة أشوف people بتتكلم عن implant to crown. I'm not a student yet.
This was really very interesting for me too, because lately we've been reading a lot about short implants, and that there is no crown implant ratio, and that it's fine to put a 4 millimeter implant on a 10 millimeter crown. So this was really
أنا
interesting.
حسيتها neglected جدا بقالها فترة كبيرة. أنا اتصدمت إنه إيه ده حد بيتكلم عن crown to implant ratio.
Yes.
It can cause in 12% أو sorry to 12% total stresses to the cortical bone. So as it has been always advisable to not increase the crowd implant ratio more than 2 to 1. So increasing in a prospective study, 3 years study, the higher bone loss was with the implants that have a higher crown to implant ratio. Okay, talking about the restorative material. The restorative material should have both the biological.
Let me stop you at this crown implant ratio. For a clinician, why is this relevant to me? How can this be relevant to me when I'm designing or choosing an implant length, or I don't have enough bone? What do you think I should measure and think of if I'm going to put a 4 or 5 millimeter implant?
The inter-arch space?
Exactly. I should imagine, or even do an imitation, do a wax up of the crown that's going to be fabricated, and measure the length of the crown according to the inter-arch space. And if I find that I have vertical bone loss and I'm going to do a really long crown while I'm going to insert a 4 millimeter implant, it will be alarming for me. I cannot put 4 millimeter implant with a 12 millimeter crown. It will be a 3 to 1. Imagine. I think they mentioned the 3 to 1 ratio somewhere. They said that the failures is really high with the 3 to 1 ratio.
Yes. So, that's why I said that if I increase it more than 2 to 1, there will be a high risk for pre-implant.
Yes. So maybe at this point, I will have to go for vertical augmentation instead of choosing the simple option of short implants.
Yeah.
So again, which goes where?
Yes. Again, yes. The same what I say. When to do what?
Very interesting.
Okay. Talking about the abutment interface and restorative material. Restorative material should be both biologic and has biologic and bifunctional goal. And what I mean by biologic goals is that it should have low plaque formation, that it is soft, it does not allow for plaque accumulation and bacteria to adhere on it. And biofunctional goals mean that the tissue should allow for both tissue integration and material strength and whatsoever. Okay, some studies suggested that the certain material as gold, titanium, and zirconia more resistant to bacterial colonization than others. So it's more advisable to use gold, titanium, or zirconia. Okay.
I really love the design of your PowerPoint.
Okay, يا رب. أخدتها من صالح، يعني قلت صالح على السايت وقال لي عليه.
Very nice. I really want to have all these designs.
بعدهم لحضرتك كده. Okay. Talking about the bone loss. I think we talked about this concept before in one of the papers of the new classification, that bone loss occur before the final prosthesis placement.
Yes.
And most of the bone loss occur due to the implant positioning or the prosthesis procedures as impression taking, displacement of the gingiva, and all this. This can cause inflammation and bone loss. But the final prosthesis has nothing to have with the bone loss.
If it's properly done, of course.
Yes. Okay. So to sum up all this, the paper كان عندها conclusion بصراحة، بس أنا حسيت إنه إحنا بنعيد ونزيد في نفس
conclusion was really too long.
وبنقول نفس الكلام، فما أنت قلت فوق. فهي إنه حاجة، إنه اللي هنقول حاجة نقول when to use what، يعني when to فعلا when to use what، أستخدم إيه، لأن كل study مختلفة تماما عن الثانية، لأنها كل study بتدرس فاكتور غير الثانية. انا مش هينفع اخد حاجه واحده واقول ان هي دي بقى احلى حاجه في الدنيا ويلا نعمل كذا. فهي انا لازم اعرف انا بستخدم ايه امتى. لو هستخدم شالو امبلانت هخليها وايد، لو هخليها سوري نارو، لو هي دي بخليها تبقى وايد. اعرف امتى اعمل بلاتفورم سويتش، امتى ما اعملش نون بلاتفورم سويتش امبلانت، امتى احط عدد امبلانتس اكتر لو انا هعمل كانتيليفر. بستخدم، احاول على قد ما اقدر ابعد عن الديزاين اللي بتبقى فيها سبلنتد امبلانت. اتكلمنا على حاجه زي كده قبل كده في بيبر لصالح سبلنتد امبلانت. بس انا كده خلصت.
ثانك يو.
يلا سريع كده.
انا بس في كذا حاجه عايزه اعمل لها امفاسيس. احنا عايزين كان يو ستوب ذا شيرنج او انا واقفه؟
طبعا. لا انا ممكن ماشي.
اوكي. كان في كيس كانوا حاطينها، كانت حلوه قوي، كانت صوره كلينيكال PDF for the restoration that was impinging the soft tissue and then the restoration when it was modified and the embrasures were open. كنت حابه قوي ان انت تحطيها في الباوربوينت لانها كانت very alarming and significant. يعني ممكن نبقى نبص عليها مع بعض. لو تقدري تدعبسي كده على PDF لحد ما نخلص الدسكشن نحطها برضو، لانه يعني it was very interesting and clinically relevant.
اجيبها حاضر.
فخلونا نفكر كده، احنا طلعنا بايه النهارده؟ What's our conclusions? What did we learn today? أول حاجة إنه platform implants are so far proving that it's better than the non-platform switched implants or the matched platform implants. But we still have to consider the final diameter of the implant platform and the crown size I need to fabricate. You cannot place a very large crown on a very narrow implant because you will still have a problem with the emergence profile. The emergence profile حاجة من الحاجات اللي هم they stressed on إنه you have to have a proper emergence profile that matches the emergence profile of the natural tooth. The more you match the emergence profile of a natural tooth, the more health and hygiene maintenance you will gain. فدي أول حاجة. الحاجة التانية they mentioned إنه sometimes when you place your implant a little bit deeper in case you have to use a narrow implant, more sometimes you don't have enough bone. يعني practically speaking بقى خلينا نفكر. Sometimes you don't have enough bone and you will not do bone augmentation for all the cases you have. So sometimes you go for a narrower diameter than the ideal you want to place. Let's say you are replacing the lower molar, so you put a 4 or 4.5 millimeter diameter implant. This is not ideal. Usually you need a 5 or 5.5, which will be great. But where is the ridge that can have this implant? So you don't always have this luxury of placing a large diameter implant. So
أنا لقيتها ضغط. أنا آسفة إني بقاطع حضرتك بس لقيتها.
لا no problem. هنحطها. So they said that you can overcome this problem by placing the implant a little bit deeper, and by placing the implant deeper, you can have a vertical space to create and يعني ايه مش abrupt emergence profile, a gradual emergence profile to match as much as possible the emergence profile of a natural tooth. So this is another important point. The peri-implant mucosa always has to be probable. The probe has to go everywhere, all around the implant in the 6 probing points. And for our dear friends, you have to probe around your implants. Discovering the peri-implant diseases as early as possible is really important and crucial for the survival of this implant and for the progression of the disease. And if your crown does not allow you to probe properly around the implant, you have to modify this crown. وهنشوف دلوقتي في الإكزامبل اللي رؤى هتحطه how can we modify our restoration to be more hygienic and more healthy and to increase the survival of my implant, especially if it was a bridge. اوكي. ايه تاني؟ عايز تقولي حاجه في الكونكلوجن يا رورو؟
لا هو بس اللي انا قلته تبقى عارفه بستخدم ايه امتى وبس.
يس. وكان في حته مهمه انا كنت هقولها. طب قولي دينا، انت كنتي عايزه تسالي على حاجه، كنتي رافعه ايدك؟
يا دكتور سؤال. سؤال مش conclusion يعني. لان الحته دي يعني برضو رورو ذكرتها بس انا ما فهمتهاش، اللي هي الحته بتاعت ان platform switching may be beneficial if provisional and final restorative contour remain maintainable to both the patient and the dentist. يعني ايه؟
قولي تاني كده.
Platform switching may be beneficial if provisional and final restorative contour remain maintainable to both patient and dental care provider.
دي عايزه تجاوبي يا رورو؟
يعني لو حضرتك، لا قولي حضرتك.
لا قولي وانا لو كده هكمل.
انه يا دينا انه انا اعرف انا اعرف اعمل ريستوريشن، البيشنت يعرف يعمل هايجين، وانا كمان اعرف اعمل هايجين از ادفانس لما يجي لي في المينتنس فيزيتس يعني. انا لو انا شور انا 100% شور خاص ان انا لما اعمل بلاتفورم سويتش امبلانت البيشنت هعرف احط ريستوريشن. من عشان كده لازم اعمل بقى استدي للكيس قبل ما اشتغل. يعني انا هحط مثلا موك اب او واكس اب على الكاست واشوف انا عملت ريستوريشن مش اوفر كونتور، مش مثلا جايه ميزيال اكتر من ديستال او ديستال اكتر من ميزيال او في اي مشكله في الكونتور فهتخلي البيشنت يعرف يعمل هايدين وانا عارف اعمل هايدين هجو فور بلاتفورم سويتش تيم لو هلاقيه.
maintaining الاورال هايجين يعني.
بس خلي بالك هي بتسال الحاجه فيري سبيسيفيك، هو ليه محدد ده للبلاتفورم سويتش امبلانتس بالذات؟ خلينا نفكر. if I'm replacing a lower molar خلاص، وانا اللور مولر ده ايديالي احب احط له امبلانت مثلا 5.5 6 عشان يبقى عندي emergence بروفايل مش ابرابت قوي، يعني ما يبقاش الامبلانت قد كده والكراون طالع عامل emergence بروفايل او كونتورنج فظيع. ما هي دي مشكلتنا، ان احنا الدايمتر بتاع الامبلانت is narrow while the crown contour or emergence profile is really huge. This creates an undercut that the patient cannot clean. Okay? طيب ليه بقى برضو again specifying for platform switched implants? Because sometimes if you don't have enough bone to place the large diameter you want to place, so you know you're going to place a 4 millimeter for example, I would choose not to put a platform switched implant عشان الدايمتر بتاع الابطن بتاعي يبقى as large as possible. فاهمه الفكره؟ الفكره ايه؟ البلاتفورم switched implants الدايمتر بتاع الابطمنت is smaller than the implant platform. طب what if the implant platform اصلا is small وانا كمان هعمل platform switching يبقى I would use an even smaller abutment 3.5 مثلا. اوكي؟ ف this will create a really abrupt emergence profile which will be اصلا سبب من اسباب البيري-implantitis او inaccessibility for cleaning. فهو بيقول لك انه sometimes you have to use a non-platform switched implant to avoid المشكله بتاعه small diameter and large crowns
اللي هي اصلا عشان النورمال فاريشن، يعني مش حاجه باختياري، انا عملتها مضطريه
عشان ما فيش enough bone.
بالظبط.
انا مش هعمل augmentation، البيشنت مش عايز يدخل في augmentation. I want the implant to be straightforward. Don't go for platform switch بقى ساعتها. go for matched abutments عشان يبقى at least الابطمنت قد الامبلانت بلاتفورم فيقلل شويه الابرابت بروفايل. وفي نفس الوقت I will place it a little bit deeper عشان يبقى فيه gradual emergence profile.
طب دكتور هو مش الجرادوال emergence profile ده انا مش متخيلاه برضه قوي، لان ده في البون ما هواش في السوفت تيشو. ده هيبقى انا بنزل الدبث قوي.
ده في الكراون، ده في الكراون اصلا، في الكراون ديزاين.
البدايه دينا، بدايه زي الصوره اللي انا كنت جايباها، بدايه الريستوريشن عامله ازاي وهي طالعه في السلك. انت بادئه من حته نارو جدا وبتطلعي بقى عشان تفل الحته الكونتور بتاعت السن كلها.
يعني هو مش بيتكلم عن الانسرشن دبث بتاع الامبلانت،
هو بيتكلم عن الانسرشن دبث بتاع الامبلانت اللي منها هيطلع الايمرجنس بروفايل بتاع الكراون. فهو الناس have more vertical space هيبقى عندك space to go gradual كده 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 كده.
يس
مش مره واحده. لو انا شالو اضطر مره واحده اعمل كده. شايفه الانجل بتاعتي؟
يبقى
في الاخر الريستوريشن اوفر كونتورد.
يس
واللي accessible for cleaning.
فهمت تمام.
بصي يا دينا، بصي دي لحظة واحدة ظهرت. بصي الصورة دي، ايه ده؟ سوري. بصي الصورة، الحتة دي شايفاها؟
اه
هي دي ان انت عندك اهو هنا بلاتفورم سويتش. بصي الاباتمنت، بصي بقى بداية الكراون عاملة ازاي.
اصغر.
بقى تقفل الحتة دي كلها. شايفة بقى عملت اوفر كونتورنج هنا ازاي؟
مم.
هنا مش
اه
هعرف اعمل هايجين. البيشنت مش هيعرف يعمل هايجين برضه، ما هنا
بالظبط.
كده تبقى القفلة تنزل.
بالظبط صح. ايوه يس.
very good. هات لنا بقى الصوره بتاعت الريستوريشن كده.
حاضر.
انا بصي انا هقفل اللايف. ثانك يو سو ماتش يا رؤى، بجد انا اي انجويد جدا 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 جدا، من المرات اللي فعلا انبسطت فيها جدا. اي انجويد جورنال كلوب واكشلي يو اكسبلين حاجات احسن ما هي مكتوبه في البيبر. يعني اللي قرا البيبر بس الشرح كان احسن من اللي مكتوب في البيبر. انت
يس
فهمتي كويس قوي.
انا والله الحته دي كله قريته كذا مره ومش فاهمه، يعني فعلا الكلام ده انا قريته كذا مره ومش فاهماه. فرورو لا بجد عايش والله. حضرتك قفلت اللايف؟
قفل حالا اهو.
مش عايز